Bismillahirrahmanirrahim. Today we will discuss our lecture about pneumonia with you, Professor Ragia Sharshar, Assistant Professor of Chest Department at Tanta University. First of all, we have to define what is meant by pneumonia. To define pneumonia, we have three key words. First is the word acute, which means that the disease has a short course of disease till the symptoms appear, from the beginning of the disease till the appearance of symptoms. Second word is pneumonia is an inflammation, which is a type of pathology which including both infectious and non-infectious. And the second key word is the site of this disease is in the lung parenchyma, which means it's affecting the alveoli, giving a picture of pathological consolidation in the lung tissue, which means that there is an exudation, which what is meant by exudation? It's a fluid rich in protein. This exudation is filling the alveoli and giving the picture of consolidation. Again, the term of pneumonia including both infectious and non-infectious causes. Otherwise, we can define pneumonia as two parts clinically, according to the course of the symptoms appearing on the patient. The first is community-acquired pneumonia, which is meant by pneumonia occurring outside the hospital, and the hospital-acquired pneumonia, which is pneumonia occurring after 72 hours or more after admission to hospital. Well, after defining what is meant by pneumonia, we have to classify this disease, which means that to have different categories of the disease. Is it important? Yes, because this classification helps the patient and the doctor to find the proper treatment for the condition. First of all, we have to classify anatomically, etiologically. Meant by anatomical classification, it's meant how far or how extent is the disease. Is it affecting only lobe, or a segment which is much less than lobe, or a subsegmental, which means that the disease affecting small area. This is of course carry good prognosis than affecting more than lobe or bilateral of the disease. So the anatomical classification is meant by how extent is the disease. A term of bronchopneumonia means patchy, multifocal, and bilateral. It's meant that the pneumonia extending more distally towards the bronchi. Classical pneumonia occur at the alveoli, alveolar duct, and alveolar sacs. But when the disease or the inflammation extending to reaching the alveoli, it can be termed bronchopneumonia. Of course, this term is much historical. It's not much used nowadays. Second classification is etiological classification. It's important because I have to define why this disease, why I get this disease in my case. Is it caused infectious from bacteria I catch from the community, such as the typical? The most common is Streptococcus pneumoniae, Haemophilus influenza, or Staphylococcus species, and a typical organism like Legionella mycoplasma. This, if I have a clear idea about my bacterial infectious cause of my pneumonia, so I can have the proper antibiotic for each organism. If I have pneumonia and there is a specific cause of this pneumonia, so I have the specific to take the specific treatment. If I have tuberculous pneumonia, so I won't be cured unless I have this anti-tuberculous drugs. So this is much important. The cause may be infectious, other than the bacterial may be viral or fungal or parasitic, and this is mainly occur in immunocompromised patients. Apart from the infection, it may be the cause of my pneumonia is non-infectious causes, which means that this inflammation occur not due to agents that enter my biological agent that enter my lung, but due to another agent, either chemical agent or physical agent. This chemical including lipoid pneumonia due to aspiration of oily material, or physical pneumonia due to exposure to irradiation. If I'm a cancer patient and I have radiotherapy on my chest wall, like breast cancer patient. And again, if I have aspirated something which is not meant to get inside my lung. This normal aspiration means that something abnormal that get inside my trachea. Second classification is clinical classification. Why I get this inflammation? I can classify it according to the site where I get my infection or my inflammation. If I get this infection or inflammation from the community, which means that outside the hospital, or within the first 72 hours of hospitalization. Why 72 hours? Because this is the incubation period of average or most of the organisms or the agents, which means that I get my inflammation or infection from the community. I can further classify this community acquired pneumonia according to my condition. If I am a healthy, younger patient and without comorbidity, so most likely I can get Streptococcus pneumoniae or atypical organism. This is the most common organisms to affect this kind of patient. But if I am over 60 years and with comorbidity or other diseases, or I have chronic lung disease, so most likely I get a gram-negative organism. If I have risk factors for aspiration, so my infection is mostly likely I have mixed infection. On top there is anaerobes with gram-positive inflammation. If we are talking about hospital-acquired pneumonia, it means that pneumonia developed after 72 hours, and I can further classify it into early onset, which is occur early in the first 3 days, and the late onset in the after 3 days of admission to the hospital. In the early onset hospital-acquired pneumonia, most likely I have Streptococcus pneumoniae and the atypical organism. In the late onset, I most likely get infection from inside the hospital, which is most likely more resistant organisms such as gram-negative Klebsiella and Pseudomonas. If I am admitted in the ICU and I get pneumonia, so most likely I get a gram-negative organism or a Staph aureus or atypical Legionella or Pseudomonas. This is the most common organisms that usually present at the ICU. So if I am admitted to ICU and I get infection, it's most likely from these organisms. What about my condition? If I am immunocompromised, this mycocytic organism is not much likely to be bacterial. It may be always viral or fungal or parasitic. So, and if it is bacterial, it will be much about Legionella, Staph aureus, and gram-negative. So again, from my condition as a patient, the doctor can predict which organism that causes me this pneumonia. What about the pathogenesis? How can I get this inflammation? Either by inhalation, which is most common, or by aspiration. But for aspiration of oropharyngeal secretion, there have to be a risk factors for that. The healthy individual usually has no risk of aspiration. Which has risk of aspiration? Persons with factors that affect the protective cough reflex, like alcoholism, general anesthesia, or seizures. If I have any of these factors, so I am more likely to have aspiration of my oropharyngeal secretions. Again, if I am not healthy patient, I have chronic lung disease, so I can have this inflammation due to colonization, which means that I have the organism normally inside my unhealthy lung, and if I have lower immunity or I catch infection or I have infection, so this will propagate of the already present organisms such as Pseudomonas inside my lung, and I have colonization, not inhalation. And heterogeneous spread, where I can get inflammation through the blood-borne route. What about the pathologies? There is 4 stages of pathology in the pneumonia cases. In the pneumonia cases, first of all, we discussed its inflammation. So for inflammation, there is engorgement of the blood vessels, and there is congestion that affecting the lung parenchyma, which is mainly the alveoli. So first of all, the alveoli is filled with the blood vessels is engorged and vasodilated. Then the fluid passes through the blood vessels due to disturbances in the permeability from the blood vessels to the adjacent alveoli, which means that the fluid passes from the blood vessels inside the alveoli. Normally, alveoli is filled with air. If it's filled with fluid, which is rich in protein, so it's a stage of congestion or exudation. Then this condition where the protein is high, this gives more chance for the protein in the exudative fluid to be more having the picture of hepatization, like liver. So the intra-alveolar exudation will be much coagulated, as the protein normally, when it's long standing, it's coagulate. So it gives appearance of hepatization of the lung. It means that the lung is transformed to be like the liver, and the RBCs and fibrin is escaped from the blood vessels and filling this exudation. So it gives it the red color. So it's called red hepatization. After a while, and the third stage will be the green hepatization, where the RBCs are destructed and the hemoglobin is coming out from it. Then the RBCs gives the color of gray due to the white blood cells back into the alveoli, and the erythrocytes are lysed. The last stage is stage of resolution, where the exudate is removed and the vein system is working. This means that I am in the ongoing of the good prognosis. I am on my way to recovery from pneumonia. This is a picture of hepatization of the lung, which means the lung is much likely like the liver. How the patient is presented to me? What is the clinical picture of a patient which is suffering from pneumonia? First of all, the symptoms will be non-specific, headache, malaise, nausea, vomiting, but much important is the presence of fever. The cough will be early in the form of dry cough due to irritation, and then the sputum will appear. And the sputum may be bloody due to RBCs escaping into the alveoli and coming with the sputum, or may be rusty when the RBCs are distracted and the hemoglobin is turned into hemosiderin, giving the rusty color. Of course, there will be exertional dyspnea and pleuritic chest pain, but pleuritic chest pain occur mainly when the pneumonia is close to the pleura, because we know that the parietal pleura is the only part of the respiratory system that has sensory innervation. So to feel a pain in my chest, it means that I am affecting the parietal pleura, not only alveoli, and thus this means that the pneumonia is not deep inside the structure of the lung, but means that the affected part is near to the pleura, so I can feel my. What about signs? Signs will be general: fever, tachypnea, tachycardia. The importance of these signs, it gives me idea about the prognosis of the disease. It gives me idea about if my patient will be a good recovery or a bad prognosis. It means that it's a marker of severity. Not all patients have tachypnea and tachycardia and central cyanosis, but if I found these signs or general signs, this gives me alarm. This patient is not feeling well. This patient must be admitted, and this will be discussed in the marker of severity. About local signs, inspection will be limited movement, limited expansion on palpation, dullness on percussion, auscultation, bronchial breathing. All of these clinical signs will be discussed in details in the practical round. So this is what we call the marker of severity. It means that when I found these markers, it gives me idea about this patient is in severe condition, this patient is to be admitted to the hospital, this patient can't be treated at home. So if the marker of severity is present, so patient have to be hospitalized. If marker of severity is not present, patient can take his medication at home with frequent visiting for the hospital for checkup. The marker of severity, from this slide, we can say that there are signs that the patient is not hemodynamically stable. His vital signs are not all right. He is affecting his mentality. He is suffering from confusion. His temperature is not well. He is suffering from hypothermia, hypotension, tachypnea, or tachycardia. Overall, we have to put a marker of severity as regards the oxygenation of the patient. Is the oxygen is getting to the tissue, which is the main function of my respiratory system. If there is hypoxia, PO2 less than 50% or PCO2 more than 60%. Also, if the patient is more than 65 years, this makes there is a marker of severity. This patient can't be treated at home because he will be in danger. This is all is a marker of. What is a complication of our disease? It means that this inflammation or infection can spread, either spread locally to affecting other part of the chest, like lung abscess or pleural effusion, or become this pneumonia can unresolved, or the patient deteriorated to acute respiratory distress syndrome and respiratory failure may occur. This is of course not in each patient, but it may be complicated some patient, especially if there is a high marker of severity. And systemic infection may spread into bacteremia or septicemia or metastatic abscess, or may end in DIC and multi-organ failure. Before we discuss the investigation, we have to separate between two important terms. The first is unresolved and the other is recurrent. Unresolved means that my pneumonia is not getting recovery. I am not get off my pneumonia during the usual condition, which is from 5 to 7 days up to 14 days. So if my pneumonia remains as symptoms and signs for more than 2 weeks, so my pneumonia is unresolved. There is lagging of in the prognosis of pneumonia. So I have to check my patient. I have to check my treatment as a doctor, and I have to check my patient as a condition. I have to check my treatment if I am not giving adequate treatment or improper treatment of the patient, or if the patient is not taking my medication seriously. And second, I have to revise my patient. If there is a specific etiology, I didn't get the proper treatment for it. If there is underlying pathology, which means that pneumonia is not the only pathology, but it's part of another disease. Pneumonia is caused by underlying foreign body. Pneumonia is caused by underlying cancer. So without resolving the underlying pathology, my pneumonia won't be resolved. Or occurrence of complication, and makes my recovery from pneumonia or resolving my pneumonia is not achieved, and this is as in cases of emphysema. Or I have lower pneumonia, patient with hepatitis, patient with HIV, patient with bad liver condition. All these patients may have unresolved pneumonia, which means that the pneumonia persists for more than 2 weeks. The other term is recurrent pneumonia, which means that I have separate attacks of pneumonia. What's meant by separate? Meant by separate that there is a complete recovery from one attack, then a period in the middle, which is I am totally free, I am not diseased, and another attack is coming with pneumonia. So if I have 2 or more separate attacks with complete resolution for a period of months in between these 2 attacks, so and this is occur in 1 year, which means that I have pneumonia when I'm a child, I have pneumonia when I'm old patient, old age. This is not recurrent pneumonia. It means the recurrent pneumonia occurring within 1 year. I have different attacks of pneumonia within 1 year, and these attacks in between I am completely free for at least 1 month. Why this is occur? Due to 2 causes. Either the cause that my lung is not alright, there is a recurrent in the same site in the lung. This means that there is endobronchial TB, endobronchial foreign body, there is bronchiectasis, which means that my lung tissue is not healthy. So I am more virulent for having this infection. Or the second cause is there is a recurrence, but at different site, which means that my total immunity is not okay. It's not about the lung tissue, it's about my whole immunity in the patient immunodeficiency or cystic fibrosis. So I have defined what is pneumonia. I knew what is the causes of pneumonia. I knew what is the symptoms of pneumonia. I knew what is the complication of pneumonia. I have to confirm my diagnosis. I have to do investigation. For investigate a case of pneumonia, I can do radiological, I can detect the organism which is causing my pneumonia, I can do blood examination and arterial blood gases to assess the severity of pneumonia. So, for radiological assessment, there is a keyword that there is no pneumonia without chest radiograph, which means that I can't diagnose pneumonia without chest x-ray. If I have chest x-ray with signs in it, which is an opacity, plus the symptoms or signs, so I have pneumonia. If I have symptoms and signs and there is no opacity in the chest x-ray, so it's termed chest infection or bronchitis, it's not pneumonia. So pneumonia means, so simply, symptoms plus opacity in chest x-ray. So chest x-ray is a cornerstone in the diagnosis of pneumonia. Another presentation in chest x-ray may be cavitation or bulging fissure or miliary pattern or pneumatocele or interstitial pattern. For each pattern of these, I can predict again which organism is causing my disease. So the idea all about discussing this pneumonia today is how to predict the organism from the pattern of the disease, from the timing of the disease, from the symptoms of the disease, or even from the radiology of the disease. This will be much important for the detection of the proper treatment. This is X-ray with pneumonia on the. This is pneumonia on the right side. This is pneumonia on the right side. This is bilateral pneumonia on both sides, right and left. We see the opacity. And this is pneumonia with on the right image is pneumonia taking the whole of the left lung, and on the left picture the pneumonia is presented with necrotizing pneumonia, which means that there is an abscess in the right lower loop, right lower lung. More investigation to be done is about sputum examination to give me idea about the organism. I may take this sputum and giving a gram stain for gram positive or the Nielsen stain to assessing TB or the pneumocystitis carniae, GEMSA stain. I can do sputum immunodetection or sputum culture. All this will give me a good clue about the organism that causing my pneumonia, and again this will be very important in my treatment decision. If I'm not getting sampling from the sputum easy by coughing, so I can have more invasive technique to have sampling of my secretions from inside my chest, from inside my lung. This is by nasopharyngeal swab, bronchoscopy, transtracheal, thoracentesis, CT guided biopsy, or even open lung biopsy. This is not much doing in pneumonia. Blood examination will give me idea mainly not about diagnosis but about the severity of the pneumonia disease. If I have leukocytosis with left shift, this will be a bacterial infection, absence in the old patient or debilitating patient. Leukopenia, this is a sign of sepsis and poor outcome. Blood culture I can do to assess septicemia or bacteremia, and electrolyte give me idea about the organisms such as hyponatremia and legionella. So blood examination gives me idea about the severity of my condition or severity of the pneumonia. EPG will be very helpful in my decision of hospitalization or not, because if the patient is needing oxygen, he must be hospitalized. Plus, pulse oximetry less than 90% oxygen indicates significant hypoxia, and the patient must be hospitalized. This is again about the risk indices. We see the temperature, blood leukocytes, the oxygenation. I can give a number for each marker of this severity, and I have to get a score. If more than 6, this is hospital acquired. If less than 6, there is alternative process. This is an example for the severity marker uses in detecting the prognosis of. What about the treatment? Again, we return to the term. It is community acquired or hospital acquired. If it's community acquired and the patient is healthy and no modifying factor, I much likely to treat him with macrolide or doxycycline. If a patient who is outpatient and community acquired but with modifying factor, I will add beta-lactam to macrolides or have antipneumococcal. If the patient is inpatient but not in ICU, I will make my treatment in the form of IV if the patient is in the hospital. If the patient have cardiovascular diseases or modifying factor, I will give beta-lactam plus macrolide, or I can give antipneumococcal fluoroquinolone. So the decision depends where am I? I am taking medication at home or in patient, which is mean in hospital, and about my condition, is there is severe condition or not, I have underlying disease or not. This will assess my decision for the treatment. If patient is in ICU, I have to assess, is there a risk for Pseudomonas or no risk for Pseudomonas? If there is a risk for Pseudomonas, I have to give a combination therapy, IV anti-pseudomonal beta-lactam plus IV anti-pseudomonal quinolone, or IV anti-pseudomonal beta-lactam plus aminoglycoside, or IV macrolides or anti-pseudomonal fluoroquinolone. What is meant by modifying factor? How can I predict that patient most likely to have this organism? For example, if the patient is age of more than 65, has beta-lactam treatment, is in 3 months, alcoholism or multiple comorbidity, so most likely this patient have drug-resistant pneumococci or penicillin-resistant pneumococci. How can we predict that the patient has Pseudomonas or not? If the patient has underlying bronchiectasis, exposure in daycare center, has steroid treatment or broad-spectrum antibiotic or malnutrition, so this patient has modifying factor for Pseudomonas, which means that he is much likely to have this Pseudomonas. So my treatment must include a treatment for Pseudomonas if I have patient with these criteria. Second condition, if the patient has hospital-acquired pneumonia, which means that he gets infection from inside the hospital. In this condition, if he has no risk factor and the early onset with no other disease, so I can give monotherapy, ceftriaxone, levofloxacin, ampicillin, or If my patient has a hospital-acquired pneumonia, with late onset disease and risk factors and all disease severity. So I have to put in consideration that this patient may have a Pseudomonas infection. So this patient will, my prescription must include anti-Pseudomonal cephalosporin plus anti-Pseudomonal fluoroquinolone plus linezolid or vancomycin. So finally, we have to say that pneumonia is a condition where I must have careful examination and predict which patient to have which treatment. This is the core of treatment, is to suspect which patient is community acquired, which patient is hospital acquired, which patient has modifying factor, which patient has severe conditions that can be admitted into hospital or not, and can be take treatment in the form of oral or IV examination.